The pressing topic today
is opiate use or opiate overdose. We're gonna talk about overdose as it pertains to opiates. And not only that, we're gonna talk about how individuals overdose on opiates and what happens to them when they do.
Opioids are extremely addictive. And there was a long story of how they came to be so commonplace in American culture and how once upon a time, hopefully not as much anymore, healthcare professionals prescribe them a little too much. Even now, we're very, very, very careful about prescribing them, but guess what? People still get them illegally. They get them on the black market. There's synthetic forms of it. That's why we gotta dive into it. You are watching Doctors Saying Stuff. That is what we do. We're doctors and we shoot the shit and have bar talk about topics that you all Google and are curious about. I'm venturing to say that the majority of people who are watching this, including Jamie and I, know someone who was affected by this condition, know someone who became addicted or had an adverse reaction to opioids. It is so important that we have an open conversation about this.
I agree. And I think what's even more important is not only do me and you have an open conversation, but we have to invite on experts who deal with this condition on an outpatient basis. Like our guest today is going to be Dr. Kevin Simon, who is the Chief Behavioral Health Officer for the City of Boston, and also is a child psychiatrist who deals with addiction in children and adolescents.
That one hits me in my gut. In 2020, over 60,000 people died from opioid overdoses. It's horrific. It's all over the place. And when I'm working in the hospital on a regular basis, I still get a call about a child, not just teenagers, but even young children who overdose from a host of different opioids. So Dr. Simon, thank you for taking the time to chat with us. Here are 5 things that everyone needs to know about opioids and opioid overdose.
As I mentioned earlier, fact number 1, opioids bind to opioid receptors, which are distributed throughout the body on many different types of cells, which leads to multiple effects on your body. Molecular biology matters. Understanding where these receptors are located matters so we can better understand why and how individuals get really, really sick.
Yeah, I love that. I was a molecular biology major. I don't remember the names, Jamie, of the opioid receptors. It's like mu, kappa, delta, zeta, kappa, phi, gamma, another Greek name.
It's always the Greek alphabet, maybe. If you know the Greek alphabet, you know like half of medicine. But you're right, those are some of the names of the receptors.
Basically, every frat boy just knows half of medicine because they know half the Greek alphabet.
When you look at these receptors though, like these receptors are the reasons that people develop analgesia so they don't have pain. They also develop dependence. They also can develop a euphoria, right? That feeling that you want to have. But they also lead to respiratory depression. Some people can't take a shit, right? They get constipated because those receptors are all over your GI tract and tell your GI tract to like shut up or calm down, and you don't want that. But it's all sorts of nastiness that I think individuals need to understand.
Right on. I mean, there's opioid receptors on your heart and your vagus nerve, which can cause decreases in your blood pressure, mess with your heart rate. There's opioid receptors in your pituitary gland. Google it if you don't know what that is, but that can cause dangerous changes to your sodium levels. There's even opioid receptors present on your white blood cells, which can mess with your immune system. They're all over our body.
That leads us to fact number 2. Because they are all over the body, right? They're in areas of your brain, they actually can cause you to stop breathing. And this is something that I'm sensitive to, right? Because again, I'm a pulmonary critical care physician, which means I'm in the intensive care unit, right? I am the highest level of care. And so individuals who aren't breathing end up in my ICU. So I take care of a lot of opioid overdoses. And in fact, I probably have at least one in the ICU every single day.
And it's not just overdoses that happen outside the hospital either. You know, because even inpatient, if you're in the hospital, if I put a baby or a child on any type of pain management plan that involves opioids, we're monitoring that kid so closely, it's annoying because of how many alarms and bells go off, but it's for their safety. We're monitoring their breathing, their oxygen, their mental status, and then I'm taking off the opioids as soon as I can with that pain being managed because it is that serious and the side effects can come on like that.
And that leads me to a question for our expert, Dr. Simon. When a patient does overdose on opiates and ends up in my care, in the intensive care unit, What is the appropriate outpatient management plan once the patient is able to be discharged?
A couple of things should be best practice. So if the hospital has a consult service, there's really strong evidence that if you have such type of service, they are better at helping patients transition over into an outpatient treatment program where they can get like the medication that I just described, as well as psychological support. Persons should definitely be prescribed naloxone and know how to use naloxone. And if there's any loved ones who have come to visit that person, then I would ensure that the loved one also knows how to use naloxone, because oftentimes the person that's experiencing the overdose is not going to be able to be the person who provides them naloxone. So naloxone would be the second thing. And then the third thing, psychological support, in so much that persons might have to be admitted to the ICU following an overdose, but not particularly ready to engage treatment. And just because you're not ready to engage treatment does not mean that you shouldn't get support.
Which now brings us to number 3. There are certain factors or certain medical conditions that can increase someone's risk of an opioid overdose. If you have certain medical conditions that reduce your body's ability to clear the drug, meaning to get rid of it, to metabolize it, to break it down, such as any problems with your organs, that could increase your risk. Certain cardiopulmonary, heart-lung disease can as well. Certain sleep disturbances can. If you're on certain prescription medications, they can even interact with opioids if you are given a prescription. So that's why it's so important for anyone out there, if you are taking an opioid, if you're prescribed one, to make sure you have all the information, you're having an open conversation with your healthcare professional, and you know the risks.
There's some kind of index or something we're supposed to check.
Risk index for overdose or serious opioid-induced respiratory depression. Fortunately, it has a snappy acronym, RIOSORD. That's not snappy, but it had everything in medicine has an acronym. But I mean, there's important questions on here. Like, in the past 6 months, has the patient had a healthcare visit involving any of the following health conditions, such as stroke, heart failure, recurrent headache, substance use disorder? And there's points based on positive responses, and there's a total possible score of 146. Your consulting physician will look at your score compared to the total possible score, and that's essentially how the risk factor is determined.
It actually predicts the probability of opioid-induced respiratory depression within 6 months. So the higher the score, right, the more likely you're gonna have respiratory depression. So these are the individuals that we really need to be able to flag, watch out for, have discussions with, and probably individuals that my boy Kevin needs to talk to about their opioid use.
Which brings me to a question also, Dr. Simon, tell us what you kind of talk about to your patients about the risks.
So on this clinical tool, I can ask you some questions. So if in the last 6 months, has the patient had a healthcare visit? What type of visit? Outpatient, inpatient, emergency department, right? So there's yes and no answers to these questions, and the yes or the no correlates with a score. And obviously the higher your score, the greater the risk. There's a whole host of things that we want to be able to identify, is the person currently utilizing? And in part because you want to be well informed about how I'm going to be prescribing this medication.
Which brings us to number 4. Fortunately, there are ways to treat opioid overdose.
So what actually ends up killing individuals is the fact that they don't breathe or their blood pressure gets too low. But if you're using opioids, right, and you happen to have an opioid antagonist like a naloxone, it's going to compete with opiates that are trying to bind to that receptor. It won't allow those opioids to bind to the receptor, and you'll literally see patients wake up like that. It's almost like magic when you catch the patient soon enough.
Any patient who's in the hospital who's getting pain management with opioids will have a just in case, or a PRN as we call it, order of Narcan. And we've heard of plenty of stories of people who were found unconscious or not breathing because of an opioid overdose, and a paramedic or someone in the field had Narcan and that patient woke right up. So it really does save lives on a daily basis. But there are even ways to treat opioid use disorder. There are certain medications such as methadone, buprenorphine, extended release naltrexone that can be used to treat these individuals alongside other forms of supportive care like therapy, counseling, or seeing a psychiatrist or psychologist. So there is a treatment plan for anyone at any spectrum. So if you are concerned about yourself, a loved one, your neighbor, your friend, your cousin, your uncle, anyone, talk to a healthcare professional. That's why we're here. This is a very important one. Fact number 5, education and awareness can save lives. We've got the stats to prove it.
When you look at patients who overdose, if they're actually giving information on overdose and they're prescribed naloxone upon discharge, they have 63% less emergency department visits as it pertains to opioids.
Here's another one. After a non-fatal opioid overdose, treatment with methadone and buprenorphine reduced opiate-related mortality, death, by 59% and 38% respectively. That is a lot of lives saved.
You know, when I hear these stats, like especially the ones that you just read, I think to myself, man, I have made some mistakes. I mean, I need to be making sure that these individuals who present like this, when they get discharged from the hospital, and a lot of these patients will leave from the ICU because it's not like they really need to stay in the hospital, right? They're awake, they're alert, they're whatever. I'm wondering if I need to be prescribing this. Do I need to make certain that they have these medications to help?
And we also have to think about withdrawal. But some patients, they no longer have pain, but if they stop taking their opioids, they don't feel great. And this is a cyclical, dangerous path towards addiction. So Dr. Simon, do you see patients suffering from withdrawal? What do you do to specifically help them? What works?
There's 3 FDA indicated medications, so methadone, naltrexone, and buprenorphine. And yes, I do prescribe them working in a substance use treatment program. And I have seen individuals who have benefited from those medications.
Thanks, Kevin, for those wonderful answers. Dr. Simon, thank you for joining us on Dr. Saying Stuff. Please, if you haven't hit that subscribe button, hit that subscribe button.
And if you have specific stories or thoughts about opioids, about how they're prescribed, if they're overprescribed, if they're underprescribed, whatever your thought is, share them in the comments because it's so important that we have a dialogue about this.
I know that you don't want to be in pain, and I get it, but please, because you're in pain, before you think about taking those opiates, give Tylenol, give ibuprofen, give those medications a chance.
Please do not get opioids from the black market, from a dealer, overseas, or from any other source that isn't a trusted healthcare professional because you don't necessarily know what you're taking, how strong it is, or if it's laced. We have seen horror stories from someone who thought they were taking something, but their blood test showed something else.